Okie dokes. So just carrying on from where we left off from the beta lactams, and I said that I would go over some of the other antibiotics that are important to know about. So again, I'm just using my own notes here just because it's easier just to go through them and we can look at everything that's been said. So the next one, so I'll just take you back actually here to the classifications that we looked at in the first video, is that we talked about beta-lactams, which were a branch off cell wall inhibitors, which destroy the cell wall and cause the bacteria to lyse. There is another type of cell wall inhibitor, and these are glycopeptides. Now we discussed that beta-lactams work by inhibiting the transpeptidase enzyme, which blocks the way that the wall forms. Glycoproteins work in a very different way. They actually work at more of an intracellular level and prevent many of the essential molecules needed for the cell wall production, and as a consequence the cell wall doesn't form. I won't go into all the details of them because very few textbooks actually go into the details, and clinically it's not really relevant as such. What you do need to know is that glycopeptides, one of the main drugs in them is vancomycin, which you should have heard of before. So vancomycin, when's it used? Well, vancomycin is used, as we talked about, in coagulase negative bacteria. Okay, and so that is staph epidermis. So if I take you back to this sort of picture of all the bacteria, I mentioned here that coagulase tests can be done to further subcategorize Staphylococcus, and then you've got the Staphylococcus coagulase negative bacteria, staph epidermis. And I mentioned to you that this is a very important bacteria to be aware of because it can cause a lot of infections within prosthetic joints. Additionally, any prosthetic thing in someone, it can be a major cause of infection. So, for example, if someone has a prosthetic heart valve and they develop endocarditis, one of the main organisms considered is staph epidermis. And staph epidermis as well can affect wounds such as cellulitis. So it's always something to be aware of. And the drug of choice, as we're talking about, is vancomycin. Now, a very important thing to know about vancomycin is that it's a large molecule. And you might think, well, what's that got to do with anything? What it means is that wherever it's placed, it stays. So, for example, if you were to give this drug orally, so PO, then it will only remain in the gut. So, what does that mean? That means that if you had an infection in the bone or the skin and you give it orally, it will have no effect. All it will do is clear out all the bacteria within the gut. In fact, the only time that it's given orally is when you're treating C. diff infection, Clostridium difficile infection, which I think I've mentioned sort of here for my notes. So what does this mean? It means that if you have a skin infection or a bone infection and you're using it, it has to always be given IV. Otherwise it simply won't get into the blood, it won't be absorbed, it's too big. So it's predominantly used for staph epidermis, but another major thing that you need to be aware of, and I'll even do this in a different colour, is that it's used for MRSA. So you would have heard of MRSA, methicillin-resistant Staph aureus, and the reason that MRSA is so dangerous or so resistant is if we go back to the beta-lactams, and we were discussing this transpeptidase enzyme, okay, and I said to you that there was a protein on the transpeptidase called penicillin binding protein, and this is where the beta-lactams bind to. Well, in MRSA, okay, there is a mutation to this, okay, there's a mutation, and as a result, beta-lactams cannot bind to it, okay. they are unable to bind to the penicillin binding protein and therefore are unable to carry out an effect. And that is why we have to use glycopeptides. That's why we have to use vancomycins to destroy them. And the reason for that is because, as I discussed, they have a different method of action. They prevent the cell wall from forming, and as such can destroy the bacteria that way. So some important things to be aware of as well is that they do cause toxicity, predominantly nephrotoxicity, so they can cause damage to the kidneys. So constant renal monitoring via U's and E's or urea and electrolytes needs to be done. And they can also cause ototoxicity, so they can cause damage to the ear, although this is much rarer. They also do this thing called red man syndrome as well. This is a type 1 hypersensitivity reaction. Hypersensitivity. And what that means is it's IgE related. So in other words, it's histamine related. Okay, and so it's not unusual if this drug is given too quickly that it will cause the person to literally go red. Their whole body will go red. It looks really bad, but actually it's not that bad. All you need to do is slow down how quickly this drug has been given. Okay, so that's glycopeptides, and the main drug you want to be aware of in glycopeptides is vancomycin. Right, we'll go back to black colour now. Right, so 50 ribosomal subunit inhibitors. Okay, so this, let me explain first of all what a ribosome is so that we're aware. When you have your DNA, okay, imagine this is DNA, it's double-stranded, and when you want to make a protein, you produce something called RNA. And then this RNA is called mRNA, or more accurately, messenger RNA. This mRNA will get translated into a protein. Okay. Now, part of that translation involves using something called a ribosome, and it's literally two subunits, one that sits here and one that sits here, and it sits over the mRNA. So if this is the mRNA here, it literally sits over here and it runs across and translates and produces a protein. It builds a protein. It actually has another subunit in here called the tRNA, which builds it. But anyway, the mRNA, the ribosome, sorry, is needed. It's absolutely essential for this to occur. So just be aware that it's a thing that's needed for protein transcription and translation. So what does 50S mean? What does the 50S mean? What does the 30S mean, which comes down in these drugs here, which we'll talk about? Well, what it means is it means the sedimentation rate of these different bits. So I'll go down here and I'll just draw this out a little bit more. So I mentioned to you, you've got this subunit of the ribosome and this lower subunit of the ribosome, and then the mRNA sits in here. So if you were to put this into a centrifugal force and then let it a centrifugal spinner, and then let this all settle down, the time taken for this to reach the bottom is 50 seconds. The time for this to reach the bottom is 30 seconds. And so you can actually measure these out. And in humans, we also have ribosomes. We also have ribosomes, but ours are slightly bigger. We have 60S, and 40S. Now the important thing to know here as well is that you would think, okay, if these two are combined together, then you'd get 100S. That's not actually the case. It actually works out to be 80S, because them combined together just seem to fall at a rate of 80S. It's also the same for bacteria. I can't remember how quickly when these two are combined, but it's important to know because you might see in textbooks various things written. I think it's 70S when they're combined, but I'm not 100% sure. But usually they just refer to the 50S and the 30S. So I hope that makes sense, just that ribosomes are a important protein that's used in the translation and production of protein, and bacteria only express 50S and 30S subunits. Humans do not. We express 60, 60S, and 40S. And as a result, we can make drugs which block these. So we can disrupt these, and by disrupting them, we prevent protein synthesis. And some of the protein synthesis is necessary for the bacteria to survive. Okay, so important classes of the 50S ribosome subunits are macrolides, and these are drugs that you should have definitely heard of. So these would include things like erythromycin, clarithromycin, azithromycin. I have no idea why I've bolded the clarithromycin being most commonly used. That's not always the case. But anyway, so when are these used? Well, these are used for various infections, predominantly upper respiratory tract infections, but they're also used commonly when you have atypical bacteria. Now, just to take you back to this picture of all the different types of bacteria, I mentioned gram-positive, gram-negative, and I also wrote gram-variable. And one of the big categories that sort of falls shortly after gram-variable is atypical bacteria. You don't need to know all the reasons why they're atypical, but one of the big things about them is that they survive intracellularly, most of them. In other words, they have to go inside the cell to survive and can be very difficult to get rid of. And so creating a cell wall inhibitor, giving them a cell wall inhibitor such as a beta-lactam wouldn't work on them. And the reason is because it would have to get through our cell membrane first in order to reach them. And of course, they can't get through the cell membrane. And so you have to give these sort of drugs which work inside the cell, which will pass through our cell membrane and affect them. Okay, so hopefully that explains a little bit about what they are. And they can only be given orally, so it's very important that you just give them orally. And some of the key things that you need to know with regards to side effects is something called QT lengthening. Now, I don't know how much you know about your QRS complex and just the general ECG, but the QT lengthening is basically the period from when your ventricles contract to your ventricles relaxing and repolarizing. The longer that this occurs, the increased risk you are of going into something called Toussaint-Dupont, which is spelled like this, maybe. I think. Don't take my word, but Toussaint-Dupont is a type of arrhythmia. It's a tachycardia, so a very fast arrhythmia that can potentially be fatal. Interestingly, you treat it with magnesium. You don't shock the person. You can kill them if you shock them. You give them magnesium sulfate to fix them. But it's very important. So if you ever see that written on any patient notes or anything like that they have QT lengthening or QT prolongation, then you need to be thinking these people are not suitable for macrolides. Another big and really important thing to know for clinical practice and also for your exams is that they're contraindicated with statins. Okay, and the reason for this is because they inhibit particular enzymes which break down the statins. These are your CYP450 enzymes that they inhibit, and this is the particular one that it inhibits, the CYP3A4. But I wouldn't get bogged down. This is your P50 enzymes that it inhibits, and so by blocking this, statins don't get broken down, and they just build up, and you get toxicity of the statins, and so you can cause someone to get something called rhabdomyolysis. Oh my goodness, tongue twister. Rhabdomyolysis. I can't pronounce it. Which is basically breakdown of their muscles and can cause kidney failure, and it can be very serious. So the key points to take away from this are 50S ribosome subunits are important for protein synthesis. Macrolides block the 50S ribosome and then thus prevent protein production from the bacteria, and so the bacteria eventually die because they're unable to carry out necessary protein production. Very important side effects are to do with the QT lengthening. It can put them into a fast arrhythmia called torsades de pointes. And very high yield to know is that it's contraindicated with statins because it will increase the level of statins within the blood, which can put them in toxicity, causing rhabdomyolysis. Oh my goodness. Anyway, so other drugs that fall under the 50S ribosome categorization are ones called clindamycin. The only thing that you really need to know about clindamycin is very good for toxin production. So it's very good at inhibiting toxin production, and so it's used a lot in that. And the other big thing is that it causes C. diff. In fact, it used to be called the C. diff antibiotic or something along those lines. It's really, really good at clearing out your normal gut flora and leaving Clostridium difficile, which can cause severe diarrhea disease, which can be fatal. So people are we usually only put on this when it's really necessary because of the risk of C. diff. And then there's another drug called chloramphenicol, which is only really used in severe cases or topically for eye infection, so I don't think you need to know much about this. It's also used as a second line sort of drug for severe meningitis, but it's very rarely used. It can cause severe bone marrow suppression. Yeah, it can cause severe bone marrow suppression. It's really quite a severe drug. Okay, so the 30S ribosomes. So they're a very important drug to know about here. So I've explained what the ribosomal units are, and so you know how these work. There's a particular drug in here called gentamicin. So this is gentamicin. You should have heard of this. So gentamicin is very good at inhibiting gram-negative bacteria. So in fact, so much so that if you take a swab and it comes back and it's gram-negative, one of the first-line drugs is usually gentamicin. Sorry, it's very, very good at taking out this, and it works by inhibiting the 30S ribosome, and it also destroys the cell wall. And for the life of me, I cannot find out why. Every book just seems to say it does, and the mechanism of action is not known. What is interesting about it is only when it's given in very high concentrations immediately does it cause the cell wall lysis, and then eventually that property of it disappears. And so you actually give this in peaks and troughs. So you build it up and then you drop it down, you build it up, you drop it down. And this is just the dose that you give. You give a high dose and then you withhold the dose, and then you give a high dose and then you withhold the dose, and you give a high dose. And that's because it helps maintain this property of it. This is also for another reason though. This is not just for its cell wall property. It's actually due to its toxicity. And this is very high yield to know this, and it's actually very important. Oh look, I've given you the peaks and troughs down here in my own notes. Anyway, so the big thing to know about is that it's nephrotoxic. Okay, if you see any patients that are on gentamicin, you should be looking to see how long they've been on it. Okay, they shouldn't be really on it for more than 3 to 4 days. Okay, that's the maximum that they should be on it, unless it's for really severe infections which are guided by microbiology. Otherwise, the risk of nephrotoxicity is very high. Okay, and also additionally, if a person has gut kidneys and their kidneys are already not working, then they shouldn't really be put on this. It's a bit of a risk versus benefit case. The other really huge thing to know about, which is high yield, I'll put this in red, is ototoxicity. And this is actually probably the main side effect of this drug is ototoxicity. People lose their hearing very quickly, and so you actually need to test their hearing every day that they're on this. So it's maybe worth I don't know how much you would actually be doing this in your job, but certainly for your exams you should know that it causes ototoxicity if that comes up, and that if it said, what kind of things would you want to do whilst the person's on this, you want to be saying I would be testing their hearing, and they would be restricted to 3 to 4 days unless guided by microbiology. But yeah, ototoxicity is a really big one. And neuromuscular, so myasthenia gravis, who knows, never really heard or seen about that. Tetracyclines, okay, so these work in the exact same way. They bind to the 30S ribosomal unit. These are used for atypical organisms. Again, these are actually very useful when someone has a penicillin allergy. So when someone has a penicillin allergy, these are very useful. Now, actually, I just want to very quickly mention this because I forgot to mention it. Going back to the vancomycin, which is a glycopeptide, I mentioned that it's predominantly used for staph epidermis and for MRSA. It's also used when there's a penicillin allergy. Sorry, that was really important. I should have put that in there. So if a person has a penicillin allergy and they have a severe disease, in other words, they are receiving this drug IV, then you need to give them vancomycin, okay? Because that will carry out, as we mentioned, it will carry out very similar activity to beta-lactam, but it doesn't work in the same way, so the person shouldn't have an allergy to that. If a person, so just going back to 30S here, if someone doesn't have a severe disease, okay, and they don't need to be on an IV drug, and they're allergic to penicillin, then you can give doxycycline, you can give the tetracycline. Important things to note here is that it's not okay to give it to pregnant women and children, and this is because it can affect the way that bones grow, and it can also cause severe discoloration of the teeth as well, and that's something nobody wants. Okay, moving to quinolones. So this is actually very relevant for you guys to know because of the side effect. So first of all, what is it? Well, there's two main drugs, ciprofloxacin and levofloxacin. They work on something called DNA gyrase and topoisomerase. So all that these are, all you need to know is that DNA gyrase is something that is important for reading the DNA as it unwinds, and the DNA gyrase, what it does is it unwinds the double helix. So the DNA is in this double helix, and so for it to be read, it needs to be unwound, and the topoisomerase unwinds it and allows these proteins to come in and read it. And one of those proteins is the DNA gyrase, and so what the quinolones do is they block that activity, so the cell is unable to undergo replication or produce the proteins that's needed. Okay, so what's the really important thing to know? Well, arguably this is what you guys are interested in, tendinitis, but this is what I'm interested in, and it's also a major thing to know about your exams, is that it's prolongation of the QT. So just like with the 50S ribosomes, the macrolides causing the QT prolongation, the quinolones also. So if you remember that this can cause Torsades de Pointes, or Torsades de Pointes even, I always add the S when I shouldn't, which is a tachyarrhythmia, which can be fatal. And again, so if you see anyone, or if your exams ask you and they say they've got a heart arrhythmia, then you should absolutely be querying whether they should be on this drug or not, because it can cause a fatal arrhythmia. The other thing that it does is causes tendinitis, and the exact mechanisms of this is not understood, but it's a major cause of Achilles strains, etc. And so that's very relevant, because if you have a patient come in and they are out running all the time and they've had a bad infection such as a UTI, these are often used for urinary tract infections, and they're also used for upper respiratory tract infections sometimes as well, depending on the infection, then you should query whether they've been on this drug, because it can cause tendinitis and actually cause severe injuries such as sprains, etc. So that's definitely something worth taking note of. I'm going to go to inhibitors of folate now, because this is an important drug as well to be aware of. This one's called trimethoprim. So to understand this, you just need to know that folate synthesis is really important for DNA synthesis, especially through this enzyme called dihydrofolate reductase. I would never get bogged down memorizing this. In fact, some of this I don't even need to know. Actually, well, never mind. Anyway, the point is that folate is really important for DNA, and the reason why is because it produces dithiamyl monophosphate. I think that's how it's pronounced. I can't remember. But anyway, what this is this is a nucleotide that's really important for the production of DNA. And so several steps back, so moving up into this area, in order for that to be formed, folate has to be reduced and taken away some of the hydrocarbons, and so dihydrofolate reductase does that. By blocking that, you don't produce this, you don't produce DNA. Simple as that. And that's really all you probably need to know for trimethoprim. If you're interested, you can always pause this and have a wee read of some of the things it's used for simple UTIs. Actually, what you should probably know is it certainly shouldn't be used in pregnancy. And in my last video, I mentioned that folate is really important because even humans use it, and it's used for the formation of DNA, as I've just described. And of course, a fetus that's grown inside a pregnant mother is undergoing a huge amount of DNA replication, and so you don't want to give any drug that can inhibit that, because you can lead to severe pathologies, especially neural tube defects, so you need to be very careful of that. Also, if you're ever looking on track care or anything like that and they're on this drug, you might see that they have elevated U&Es, so their serum creatinine might be up and their potassium might be up. They don't have kidney failure, it's just that this drug maintains some of that. Okay, and maybe probably the last drug to talk about is one called metronidazole. This is predominantly prescribed in dentist practices. It's due to anaerobic bacteria that form predominantly within the mouth. Induces free radicals, which damages DNA. High yield thing to know about this is that alcohol will make you severely ill if you're on it. It really does. It's not even just a side effect that you write in the textbooks. It really, people will throw up tremendously if they're taking this drug and drink any alcohol in it. I wouldn't give it a try if you're ever on the drug. Okay, so those are some of the really important antibiotics that you should probably be aware of, which we mentioned down here. I've also included rifampicin. You probably don't need to know about this. This is for TB. It's used to destroy the monobacterium, which causes severe tuberculosis. Yeah, so hopefully that helps. If you have any questions, just write them down in the comments. I'll try and answer them as best as possible. What I would know probably for your exams is I would definitely know beta-lactams. Just know the names of them and know how they work. Okay, it's not too hard. Just beta-lactam ring inhibition, and I've explained that all in the previous video. Know the vancomycins for MRSA, epidermis, and as I forgot to mention, when you have penicillin allergies. Okay, and you need to give it IV. And then you've got other types of antibiotics which disrupt different processes within the cell of the bacteria. So hope that helps. Trying to add a bit of clinical spin to it. Cheers.